Welcome to Dr. G at the Heart of Healthcare, episode 19. I have a special guest here, Nurse Gerard Soucy, and he is here to talk to us about his personal experience as a caregiver from a spouse's perspective. Thank you for being here.
Thank you very much for having me. I'm very glad to be here.
Yeah, so good to meet you and learn from you. I've been doing a series about caregivers, and I realized I hadn't covered the spouse's perspective. And people don't talk about the things we endure in our type of work a lot. You see a lot about the daughters and the sons. We had the privilege of talking to Aisha, but I'm glad we have a spouse here. So before we get serious, do you want to tell that joke that you had up your sleeve?
I've been dying to tell this joke, yeah. And
Come on.
here we are. It's a physician and a nurse walk into a bar, and the bartender says, "What'll it be, doc?" And the nurse says, "She's the doctor."
Hi. That would be a fun night. I think it would be a fun night when that we should make that happen at some point
Right.
when I'm over there in Boston.
You got it.
Wow. So let me just introduce you. You have been a nurse almost my whole life, and I'm not trying to age you, but that's something to be proud of. Um, and and let's see, you told me you got your RN in 1976,
Right.
and you've worked all over clinical practice, ICU, hemodialysis, then you were a hospice nurse, and you have your certification for palliative care, I see.
Yep. Yeah. Started in 2012, so did that exam and then had to renew it. And it's a combination portfolio and situational judgment exercise, kind of a very interesting test. Um, but
Yeah.
I'm pretty much retired now.
Oh, okay. Well, you deserve it. You've done a lot, I'm sure. Let's see. The thing that's making me be a groupie right now is that you actually worked for the pilot site for hospice, Good Shepherd Community Care. Um,
Yeah. This was back. I think Good Shepherd was started. It was the first hospice in Massachusetts, maybe not in the country, but in Massachusetts. And it was the old model of community-based, all volunteers. And they had been established for a few years, but they were instrumental in the Medicare pilot project that led to the Medicare benefit. And they're still operating today as a, independent, community-based, not-for-profit.
That's amazing. So you have served as a community educator and hospice nurse. You have a blog, but since we're here to talk about being the caregiver of your late wife who passed away in 2016, why don't we just start by honoring her? So what do you want us to know about her?
Oh, well, I've got a picture right behind me, so should I use this one? So this is Jeanne. Let's see if we get. So that's a picture, a painting of Jeanne painted from a photograph. And the painting in the background is our daughter, Anna, who is a artist, painter. So she painted it. And this is from about a month before Jeanne died. So this is like mid-December 2015. Um, she was an educator and a counselor. She was a nurse. We met in nursing school years and years ago. Um, and I think, part of the whole experience of being, we'd been married 25 years when Jeanne got her diagnosis of mild cognitive impairment. So that kind of trajectory moving forward to her death was like, I mostly was keeping up. She set the pace. I really look back on that whole experience as just trying to keep up with her, to do what needed to be done.
Wow. And that was a beautiful presentation you shared with me
Thanks.
about keeping up with her. So I saw a photo in that presentation. It said it had the rocks and it had, her date of birth and the dash and the year she passed away, 2016, which happens to be the year I graduated from med school. And it said, "The happy heart is true." Where'd that
Mhm.
quote come from?
Um, it's uh, it's a line from the prayer of Saint Bridget, and Saint Bridget is like the patron saint of Ireland, after Saint Patrick, I guess. And Jean was a Murphy, and her Irish heritage, was a big thing. And it's a prayer that it's a prayer by a woman who says she really wants everybody to relax in heaven. And the happy heart is true really kind of speaks to who Jean was, to other people. And the stone was, Jean didn't want to talk about funeral plans or anything else like that. I mean, she would say when either of us, when we had relatives or whatever who died, would look around and say, "Oh, don't do this for me," or "I don't want that." And so the kind of embalmed body funeral home kind of thing was not what she wanted, but she pretty much said, "You decide." Um, so it was a green burial in the end, and the stone was just a stone from the site that was part of the deal. You pick a spot, and then they have all these stones you can grab.
Wow. Well, I know she was a special lady because her birthday's in February and we are pretty special, 3 days after
Okay.
mine. Yeah. So when we spoke before, you shared a little bit about, her trajectory, and you mentioned that you kind of had it easy. And I don't want to say easy like being a caregiver wasn't hard, but just relatively speaking, you had a lot of resources, the adult day program, the support group. You had the privilege of, leaving your full-time job to stay home with her and keep up with her, like you said. So um, you also mentioned some very, things that are, emotional and private, like being a caregiver, you're having a constant state of anxiety and self-doubt and loneliness. And it comes at great cost, emotional, financial, and physical. So I think, people are paying attention to that a little bit more, but you want to color that and give us a little more insight on that?
Sure, sure. So Jean's diagnosis of mild cognitive impairment was also the same year that she retired, as a professor of nursing. And she had noticed for about a year or two before, some difficulties with preparing lecture notes or managing a group of students in a clinical setting. And from that time, when we sat down and shared like the results of the neuropsychiatric testing and everything, we decided, all right, let's make every day be as good as it can be. Jean was retired, so the pressure of her working wasn't there, and we had kind of planned on that. And she had a long-time primary care provider. We had excellent health insurance and access to a really good network of care. We live in a community that has very good supports for people who are aging, a lot of resources through the Council on Aging. So we had a lot of advantages. We also knew the system. I mean, I was working in hospice at the time. So it was kind of like being able to take my professional role and apply it to what was going on at home. And I want to say something about that. I've talked with other caregivers, and I've heard from other caregivers who work, also clinicians of various types. And we've all gotten pressure to like, oh, step back, just be the husband, don't be the nurse, don't be the case manager. And I think there was one time in particular where that was such a heavy message that we fired the team.
Mm.
Because from my point of view, it's like, well, this is the most important, patient I've ever encountered, and nobody knows her better.
Mm.
Nobody loves her more. So it's important. I knew it was important for me to have supports. I went to a monthly caregiver support group. Generally, I was the only man there. Jeanne also had an adult day program, which took a lot of the, 9 to 3 pressure off of me. We also had, Jeanne had a long time therapist. Jeanne was a counselor, so she looked at therapists as like a fitness coach. And we kept her in the loop so that she could objectively give me feedback on what she thought, how she thought Jeanne was. So, it was important for me to kind of be involved and to be observant at every step of the way, and to depend on others, but to also not just like turn everything over to them.
I appreciate that. And your message is received, because I have said, something like that, maybe thinking I'm helping the healthcare professional kind of take a little bit of stress off. But, talking to you makes me see that this is the most important, patient that you would encounter. And you do need to not turn your brain off, because, you need to apply everything you learn. So thank you for sharing that. What I'm curious about, a couple things. You said that Jeanne noticed that she was having trouble, at work, as a husband, as her spouse. Were you noticing any early signs?
Yeah.
Could you share a little bit about that for our listeners?
And it's in retrospect, really. But there were a few things that we did together, that we did for fun. We liked going to performances. We liked going to music and theater. We liked going to movies, and we liked going to restaurants, just like all different kinds, just to kind of check things out.
Mm-hmm.
And looking back, it was at about that time that Jeanne was noticeably indecisive when it came to looking at a menu. And it wasn't just, do I want chicken or fish? I'm not quite sure. It was really not being able to put together what you need to do cognitively to come to a decision. And that was like the most notable kind of outward behavior that I could see, that it was difficult for her. It would become frustrating. And then she would say, well, why don't you order for me? Which she never did before. Or what do you have?
We want to be in charge.
Yeah. And so, I didn't really clue into it at the time. But one of the things, kind of in this whole trajectory, after Jeanne died, I was asked to come back to Good Shepherd and do a session on dementia care. And one of the things that I developed was, well, if we're going to talk about impaired cognition, what's normal cognition? How do we know what's impaired if we don't know what's normal? And, I settled on these 7 aspects of cognition. And, one of them is decision making, that you have to be able to do a lot of computation to actually choose. And that was like a high level cognitive function that Jeanne lost early on. That's kind of how I'm looking at it, looking back. She reported to her colleagues that it was just getting difficult to handle like multiple things. Jeanne was, that picture that I showed you, Jeanne's got a piece of paper in her hand. And in a lot of the pictures from the time of Jeanne's advancing illness, so 2013 to 2015, she often does have something in her hand, a pen, a book, a notebook, because in her work life, she was like that. She would always have one thing or another. Never a cell phone. This was pre-cell phone. But, anyway.
Wow. Interesting. So you're saying that in retrospect, but in your presentation, I saw that you put a picture of what you guys call the MOLST. We call it the PULST here in California. And I saw where it talked about you know, I can't quote it right now, but having dementia, if you're not able to eat, don't force feed me, don't give me those insures, don't do
Yeah.
that to me. And then there were a bunch of statements, please don't, please don't. That's the theme of the day, you know, the story of your love story, like you said, keeping up with Jeannie, and how she would say to you, please don't, or you would say to her, please don't. And you knew what she wanted. So was she able to put those things into the most, you know, in a
Well,
timely fashion?
well, yeah. Don't forget we our first conversation in nursing school was about death,
Mm.
and talking about death was something we did a lot in the course of our lives together. And some of it was because of our work, and also because of special interests. I mean, Jeanne actually, in 1980, was doing some work with the US Public Health Service, and they were moving toward establishing a hospice through the US Public Health Service. And don't forget, too, this is around the time of the pilot programs and all that, and just kind of a growing awareness of what, death outside the hospital could look like. And then there was an election, and the guy that came in 1981 just pulled the plug on all of that.
Mm.
All the clinical settings that I've worked in were high mortality settings. I mean, critical care, not everybody gets out alive. Specialty critical care, the bone marrow transplant unit I worked on had about a 40% mortality rate from the treatment, just because the treatment's so brutal. So we talked about that a lot, both because of our work and things in families or extended families and friends. I think one of our experiences with someone with advanced dementia was a person, a family member who was kind of carted around, and at family gatherings was present, but was just like tucked in a corner. And, some of what we talked about was like, yeah, boy, if that's me, don't do that, because we could see other family caregivers who would take, say, 2 hours to feed someone lunch because they fell asleep every 10 minutes.
Mm.
But they've got to eat. They've got to eat.
Right.
That's why Jeanne's statement in her that advance directive was, if I can't feed myself, then food takes on a different meaning. Feed me as a way to connect. Feed me because it's an enjoyable sensation in my mouth if I'm eating something good. But don't force feed me. Don't put a feeding tube. Don't give me nutritional supplements that, just don't do that.
That's challenging for families. You know, we encounter that,
Yeah,
you know, in the work
all the
that
time.
I do too. You know, we're interdisciplinary teammates, and food has such a cultural significance, and that sometimes more than pain or what the CT scan is saying is more important to the
Yeah,
family. Like, did they
absolutely.
eat?
Absolutely.
Um, yeah, I saw something you posted about ice cream. What's the significance of that since we're talking about food?
Sure. Ice cream in 2015, Jeanne's was kind of entering a more advanced state of decline. So in early March, there's a local ice cream stand that opens up, and we were there opening day, and Jeanne came to the window with me. I ordered for both of us, and then we walked back to the car, and we each ate our own ice cream. So that was in March. In April, we tried to get out the door to hit the ice cream stand just before they closed. And that was a maneuver that we had been able to do without a problem for years, have a late dinner and then, oh, quick, get over there. And we made it, but just barely, because it was difficult for Jeanne to mobilize and all that stuff. It wasn't, you know. Then in May, I would go to the window alone because getting in and out of the car for Jeanne was too much. And she was more unsteady on her feet. And so That was in May. In June, I brought our ice creams back to the car, one for her, one for me. Each had a cup. And she just looked at the cup with the spoon sticking out of it. And she couldn't put it together what to do next.
Mhm.
So at that point, from that point forward, I would get one, and a bite for me, a bite for you, a bite for me. And then in August, July, August, she would fall asleep within minutes after getting in the car. And it was about a 15-minute ride from the day program to ice cream. And she'd fall asleep, I'd get there, and she'd wake up, or she'd wake up when I had the ice cream back in the car. And then, kind of like the final ice cream in this graph, this is a graph of functional decline, was the Friday of Labor Day weekend. We went out for ice cream. Jeanne fell asleep in the car, but when we got there, she didn't wake up. When I got back in the car, she didn't wake up. And she just stayed asleep the whole time while I ate the ice cream by myself. We drove home, and I had to wake her up to kind of get her in the house. And that was 6 months. So from 6 months, from being able to walk to the window to, not substantial decline. And it was toward the bottom of that I reached out to have Jeanne assessed for admission to hospice. And that's when we hit probably the single worst event of the whole trajectory.
What do you mean by that?
So I reached out to, the only hospice that I wanted to deal with was Good Shepherd, and spoke with the director of nursing, and we were just outside their service area. So she said, well, let me just check and make sure it's okay. And then she came back. She said, yeah, we'll do it. Just understand that, if it's the middle of the night, it may take us longer to get there. And that's, factually, that's not the case. And we weren't like a super acute. So I'm like, okay, that's fine. And so we started kind of like the process, gave her the Medicare number, all that stuff. I went in the following Monday to meet with the assigned nurse and social worker. Good Shepherd, their model is for admissions to have a nurse and a social worker do it together. And so this is like a pre-admission thing where I went to the office, I told them what had been happening, and they scheduled an in-home assessment for Thursday. So on Tuesday evening, I'm sitting with Jeanne. It's about 6 p.m, and my phone rings, my cell phone rings, and it's the former medical director. And she says, Jerry, I walked into the office and I saw Jeanne's name up on the board for an admission assessment on Thursday. She says, I'm not admitting Jeanne to hospice. And it wasn't like, how are things going or what's been happening lately? It was a flat out, I'm not admitting Jeanne to hospice. And the conversation deteriorated from there. But it really was a moment where, it was like going up a set of stairs to like the door of someone that's going to help you, and then the door gets slammed. And, her argument was, she came at me very aggressively. This resulted in a board of registration and medicine complaint. But she came at me very aggressively. She says, well, Jeanne's got Alzheimer's, has she been hospitalized for pneumonia? Does she have multiple pressure sores? And I said, no. I said, but, and she just cut me off and wouldn't have anything to do with it. So after I picked myself up off the floor, and Jeanne's sitting next to me, by the way, for this whole conversation, and she's awake. But I reached out to, this is where, having a network helps. I reached out to, someone, a physician who knew us well. We were on an outpatient palliative care program with another agency. I wasn't going to use their hospice, but she just kind of like talked me down. And we had a plan, like if I woke up during the night, to give her a call. And we'd kind of like reconnect in the morning. And I was able to recover, and things weren't so acute that, oh my goodness. But long story short, it was 6 months from the time that I made that first phone call until Jeanne's death. That was 6 months. And this medical director's, her whole argument was Jeanne doesn't have a 6-month prognosis, all without seeing her. And this is someone who I've worked with, someone who had met Jeanne a number of times. And it had nothing to do with anything clinical. It was pure power play. It was pure exploiting, like, who do you think you are? I'm not admitting Jeanne to hospice just because you think she needs hospice. And the thing was, had things played out, a nurse and a social worker would have met Jeanne. They would have gotten Jeanne's records from her neurologist. I would have been able to talk about the ice cream story. Another aspect of Jeanne's presentation, clinical presentation, which is important, is that in addition to cognitive decline, she also had some atypical seizures, and was being managed for a seizure disorder concurrently with her Alzheimer's. And there's a part of the LCDs about increasing pain medications. And Jeanne didn't need increasing pain medications because she didn't have pain, but she needed constant month-to-month adjustment of her anticonvulsants over the course of 2 years.
Wow.
An agent, and then adding a second agent. And then there was also some deep prescribing associated with that. So, clinically, neurologically, functionally, all the pieces were there. And
yeah. Wow, that must have been painful. Just, they joke about, actually yesterday I was at a office party and we joked about being bad patients, for ourselves. But when we finally present our loved ones to the healthcare system for help, it should be taken seriously because we know what it is, right? And so thank you for sharing that private, painful story, because I'm sure, well, I could tell that was a big problem. And that was what I was going to ask, what challenges that you face while taking care of her. And you said it.
Yeah, that was the biggest one. I think we had resources. I mean, Jeanne had a retirement account that we spent through. Between renovations, between the day program, there still was a weekly cost to the day program. The weakest link in all of it was personal care. In 2013, I was still working full time, and Jeanne was home and she was mobile. And she agreed to having someone come 1 day a week and for 8 hours. And so we engaged a local home care agency. I interviewed them, and that was a really lousy experience because it was very inconsistent as far as who showed up. We would have someone for some number of weeks, and then all of a sudden they weren't coming anymore. We had people arrive late. We had people arrive who said they couldn't drive anywhere. We had other people who were, they were more interested in cleaning the house than in, and Jeanne also didn't like it. She didn't like someone being in the house. She wasn't comfortable with it. She was in that stage of her decline where she would also push back on things. So that was tough. There were some dicey times. I mean, things kind of, by the end of the year, we had made the decision to this isn't working. Had found an adult day health program, medical model. So they gave medications. They had a nurse on site. Jeanne loved it. We called it the club. And she went there Monday through Friday, 8:30 in the morning till 3 in the afternoon. That was a big help. I think the other tough part was just, in one instance, a nurse practitioner that we had been visiting, that had been visiting us through the palliative care program, like on a monthly basis, as Jeanne was beginning to decline, really started pressuring me to sign her onto that agency's hospice. And, you know, the thing that really bothers me is feeling any kind of pressure from anybody, and certainly, you know, in this situation. So those were, you know, and conversely, you know, the great times were those wonderful clinicians who listened. You know, I did have the advantage of being able to reach out to a nurse colleague who was working for one agency, who said, yeah, we can do it for you. She says, our overnight coverage is pretty weak, but, you know, and so that's what we did. We had a consistent nurse the whole time. Jeanne was on hospice from Veterans Day to until she died. She died 4 days after David Bowie.
That's what I was wondering about, that Rolling Stone picture. Yeah. Okay. You're answering all the questions I had.
David Bowie died on January 10th. And on January 3rd, Jeanne in her wheelchair fell asleep. But instead of just kind of like slumping over a little bit asleep, she bent over completely at the waist. And so that was on a Sunday. And so I said, okay, let's go back to bed. So I set her up in bed and I lay down with her. And then after a couple hours, got her up, and the same thing happened. After being, you know, in the wheelchair for about 10 or 15 minutes, she just bent over at the waist. You know, and part of the decline, part of the trajectory, you know, we talked about eating. I think mobility is another one that when I've worked with patients and families who, I look at both of those as real important milestones. And that just because you're shifting someone from a bed to a wheelchair, from a wheelchair to a commode, and from a commode to a bed, it doesn't mean they're not doing a lot of work. They're actually getting exhausted.
Yes.
In that transfer. And so that was on Sunday. So I thought on Sunday night, let's see how things are Monday morning. And on Monday morning, I asked Jeanne, do you want to stay in bed, or do you want to get up? And she looked at me and she just kind of said, bed. And so she stayed in bed that day. My daughter and I were the caregivers. And I said, let's see how this goes. The next day, on Tuesday, I asked her, do you want to stay in bed again? And she said, yeah. And so she was bedbound from the 3rd to her death. And as she became bedbound, she slept a lot more. When she woke up, she was brighter because she wasn't fatigued from being transferred and stuff. She was, so she was very present and bright, but she also dropped off to sleep very readily. Or when it was time to eat, she'd, you know, take a bite and then fall asleep. So by the 10th, she was declining, obviously declining. She was still, you know, interacting. But on that Monday, when I woke up and the news was, you know, David Bowie has died, it was kind of like, I'm sitting next to her bed. She's mostly sleeping. I'm scrolling, reading about David Bowie's death and listening to his music. So my experience of Jeanne's final days, and certainly of the months and the years following, are, you know, that's the soundtrack. And there's so much stuff out there. Bowie, we could do a separate podcast.
Well, we can. That. What song stands out to you?
Oh my goodness. You know, I guess the one would be Life on Mars, because it's very poignant. And it's also the last song that he performed publicly with his longtime pianist, Mike Garson. And it was at a music awards show in 2006, because he stopped touring in 2004. He had a heart attack while touring. And that was, but yeah, Life on Mars. But there's a million of them. And one of the things about certainly about like the acute phase of grief and of mourning, and finding meaning in things, or reading something and saying, oh, wow, that, so many Bowie lyrics. There's a piece of it that's like, yeah, that's talking about something that I just went through. The song, Everyone Says Hi, you've gone away, but everyone says hi, et cetera, et cetera. But yeah,
Wow.
the two of them, 4 days apart. So
That's something, in your description, again, the benefit of you being in the field, being an expert, you basically went through the fast score. So I was curious about when Jeanne, you mentioned she said one word to you, like bed. When did she, in that trajectory that you just described, or maybe before, when did she stop talking or having meaningful communication with you?
yeah, I mean, I think language and speech was also one of her earliest signs. Um, Certainly, say in 2011, 2012, when her disease was cruising along, but it wouldn't be obvious to someone who didn't know her. Are you okay, Dr. G? All right. Um, so speech and language was like, in 2012 and 2013, you would look at Jeanne from a distance and you wouldn't think that there was anything wrong. You'd step up and try and engage in a conversation, and it would become apparent that either her speech was garbled, or it was a little nonsensical, or she wasn't comprehending what you were saying, or something. But Jeanne had, because of her seizure disorder, she had a very severe fall in late 2014. And the day program said, look, if she's going to fall, there's a couple things we want. One, we want you to sign a waiver. The other is we want to know, does she want to be taken to a hospital? Because that's going to be our impulse. If she has a fall here at the day program, we're going to call the hospital, call the ambulance. So we went to see her longtime PCP to do the MOLST. And I brought her to the appointment, but I stood to the side. Jeanne sat on the examining table. Her PCP, a woman she had known for 25 years, they had a conversation, and Jeanne's, they weren't complex answers, but she was making eye contact. She was nodding. She understood. And so her communication, it wasn't always, or her language wasn't always, it didn't entirely disappear. And again, in that final week, when she wasn't getting in and out of bed, she was very non-verbally interactive, and very appropriate in her responses. So.
Hmm.
Yeah.
Tell me, you've given us so much information that I think the listeners can draw from in their own navigation of our healthcare system. I'm wondering, just for you as a caregiver, what was that decision point for you when you made the choice to leave work full time? Could you tell us about that?
Sure. Yeah, it was a combination of having been through 2013, working full time, trying to put together a plan to have someone in the home when I wasn't there, and seeing how crazy that was, expensive and unreliable, and or certainly the weakest link. We did find really reliable private care from October until Jeanne's death, again through a friend, and it was very consistent, but it was like special treatment. And then having some things in place, kind of coming to the acceptance of, okay, this is what's needed. Jeanne I need to be home full time to do everything that needs to be done to keep the home safe, to have it be comfortable, to be a place where Jeanne can be content. I mean, this is where we raised our kids. This is where her memories are. This is, where she wanted to be. So to make that all happen was, a full-time job. And,
Mhm.
we could pull it off. We were able to pull it off. Not everybody is, by any means.
Yeah. Well, some people just do what they got to do, but it's nice to have resources too.
Yeah.
Um, and that's what I wanted to also highlight, the evolution of your care team, because it's teamwork, literally not a cliche, but that makes the dream work for you to have, for anyone to have their loved one at home. It's various family members, various healthcare providers, and I saw in your presentation how it changed over time. One person would be crossed off, you'd add a new person, and
Yep.
so how maybe can we help the listeners just understand that they need to be flexible and make decisions and adjustments along the journey.
Yeah, I mean, I think for anybody entering a caregiver role, there's a couple of things that I think are important to hold on to, and one is you're doing the best you can, no matter what your resources are, no matter what the deficiencies are. You're working with what you have, and you're doing the best you can. Doubting yourself is a path to nowhere. And second guessing yourself. You make the best decision you can in the time, and then you learn from it if it wasn't the right decision, and you move on. I think for anybody encountering this and not knowing where to look, and I'll point this out, the caregiver support group that I went to had anywhere from 12 to 20 people, virtually all of them women, virtually all of them accomplished in their own right, or the spouse of someone, a caregiver now of someone who was very accomplished, professor of law or something. And so they had resources, they had motivation, they had understanding, but they were still clueless. They were still adrift.
Hmm.
So because the caregiver support group for most of them was like the first time that they ever reached out, and they found out that here's this. And through the caregiver support group, they were able to connect with other resources. So, for anybody, reach out to your local council on aging. Reach out to, I guess I hesitate to say reach out to and then list them off, because every community is kind of different. But yeah, even call up hospices or agencies saying that they have palliative care, and say, what resources can you point me to? And it is the internet. And it's very easy to find. I mean, that's how we found each other, right?
Yeah.
It's very easy to find people that are in similar boats. And I mean, right now I'm following someone on Twitter. It's a husband and wife in Louisville, Kentucky. And she has Alzheimer's. She still has speech. And they're dealing with people who are saying, "You're not really sick, are you?" She most definitely is. But it's a way to connect and see, okay, things that are happening with my loved one are happening with someone else. I'm not alone. That's probably the biggest thing. The biggest threat to a caregiver is just the isolation, because that's how your downward spiral starts. So staying connected in as many ways as possible is also really important.
Wow. Thank you for sharing that. And there's an amazing caregiver community, and you're wrapping this up for us by sharing the spouse's perspective. Um, and one picture stands out to me from your presentation, shows Jeanne laying in the bed and the cat's right there. If you like, would you like to share, since she was able to die at home the way that we as hospice
Oh,
professionals we think is the best? Would
yeah,
you share that with us? Like, how was that?
sure. Yeah. It's kind of, you know, finishing the trajectory. So Jeanne had been in bed since January 3rd. The 11th was a Monday. The chaplain and the social worker for the agency were double teaming us. So when they visited, they would both visit, and one would visit with me in the living room and the other would visit with Jeanne, and then halfway through they'd switch. And so on Wednesday, they both visited, and I ended up working with both of them at Good Shepherd later, because they both ended up at Good Shepherd.
Mhm.
So that was on a Wednesday. So when they left, my daughter and I went into the room, and Jeanne was awake, and I said, okay, let's change. Let's just change her and give her some care. So we rolled her over on her side, and when we rolled her over on her side, she let out a sound. And it was kind of like a half moan, half sigh, just kind of an exhalation. And when I rolled her over on her back, her eyes had changed. And so that began her phase of actively dying. And that carried through for about 24 hours. That was like mid-afternoon when it started, and she died about 4:30 on Thursday, the 14th. And it was very peaceful. We had actually started some oral morphine at some point while she was bedbound. I think it was like on a Thursday or Friday, after she had been bedbound since Monday, because turning her for care, she was getting stiff and sore. But she, her skin was intact. She was clean and dry. She had a comfortable bed with an air mattress. She had her quilt. And you saw that picture. Our cat, who was not a cat to jump on beds, for Jeanne's final days, she was either on Jeanne's bed facing out, or she was in the doorway facing out.
Whew. The cats know. These animals know.
Yeah.
Wow. That's making me think about, I went to a patient's house years ago, a couple of hospice agencies ago. And I have allergies, so I can't be in those homes soon. And I think this was pre-COVID, so I wasn't wearing a mask. But anyway, I was sitting there because I think this person was actively dying. And I sat on the couch because I wanted to see how the medication change was going to take effect while I was there. I didn't have time to call the nurse, you do it, and all this stuff.
Yeah.
We did some changes, and I sat there on the couch and we kind of chatted a bit. This cat jumped up on the couch and was just looking at me in my face like this. Like, basically, are you here to help them? And it was so amazing. They couldn't believe it. They said this cat is usually under the bed, and
yeah.
It was amazing. That can make me kind of tear up, because that's why we're here, though, right? We're here to help people, and we're all just passing through. So thank you for passing through, Dr. G, at the Heart of Healthcare.
Thank
Nurse
you, Dr.
Gerard.
You bet.
Yeah, thank you for being here. So listeners, I'm going to put a valuable resource of the death nurse into the show notes, and a couple other things. If there are physicians listening, non-hospice physicians, I'm going to direct you to dementia designation with CAPC, so you can be ready to take care of folks and know when they have their decline and what are some of the best practices to take care of them. And we just want to keep doing better in this healthcare system. So I hope this show does that for anyone listening. So thank you for being here.
Can I put in a plug for
whatever you want?
A terrific book that came out this May called, the title of the book is Taking Care: The Story of Nursing and Its Power to Change the World. And the author is Sarah Di Gregorio. It's a major publisher. It's a HarperCollins book. It's out there. It's great. It's gotten some great reviews. And I pointed out because chapter 5 is called Endings, and it's about hospice, and not only the author's own experience with end of life with a family member, but she interviewed me, and she came to Boston and she visited Good Shepherd and interviewed people there, and also went out on some visits with my colleague Mariana. I recommend that book. It's probably one of the best books written about nursing since Joanne Ashley, and that was in 1978.
Well, then let's do it.
Yeah,
I'm
absolutely.
gonna buy it too, because so let's save the world together. All right.
You bet.
So
All right.
hopefully I'll see you at the next ACP conference in Boston. We're gonna have to go have coffee. Have you come crash the conference?
All right. I'll see you out on the internet somewhere.
All right. Peace, everyone.
Bye-bye. All set.